Welcome to Bookfulness. We are continuing our deep dive into the human form, and, well, we're moving on. We've just left the expansive theater of the
A
abdomen,
huge area.
and now we're heading into, I guess you could say, one of the most mechanically demanding and tightly constrained regions of the body.
Absolutely.
This is episode 23, and we are officially opening chapter 6, the pelvis and the perineum.
That's right. We just finished the massive volume of the abdominal cavity, and now we are dropping down into what's really the architectural core of the body.
Okay?
So our mission today really is to build that foundational structure, the scaffolding, the joints, the muscular floor, and also the fascial lining, so we can understand how this region stabilizes the whole human frame and protects those terminal systems.
Yeah, it strikes me that if the abdomen was sort of defined by its capacity, its volume, the pelvis seems defined much more by compression and stability.
That's a great way to put it.
Everything we're going to discuss, it seems, from how the bones interlock to the tension of just a single muscular sling, it has to serve these two, absolute mechanical imperative. Successful walking on two legs, so bipedal locomotion,
Crucial.
and maintaining continence, which is fundamental. The stakes here feel really high, and the engineering compromises are just fascinating.
Exactly. And for you, the listener, understanding this architecture here is so essential because, well, so many clinical issues, think about childbirth trauma, chronic pain, they stem directly from the structural compromises kind of built into this really dense, high-stress region.
Okay, so let's start right at the base, the bony framework, the pelvic girdle. It really is this articulated ring structure, isn't it? And it looks, well, deceptively simple when you just see it isolated.
Oh, it is deceptive, mostly because it's actually a fusion of two different skeletal systems. You've got the axial skeleton coming down via the sacrum, which is basically 5 fused vertebrae.
Right.
And then you have the 2 large hip bones, which articulate with that sacrum and form the connection point to your lower limbs.
Yeah.
And each hip bone itself, of course, is also a fusion of the ilium, ischium, and pubis.
Okay, so what's the sort of mechanical hierarchy here? If it's got these dual roles, weight-bearing and protection, which one is really primary?
The primary role is absolutely weight-bearing and transference. You have to think of it as the ultimate transfer station.
Okay.
It takes the entire load from your axial skeleton, so head, trunk, arms, and transfers it safely and efficiently down to your 2 lower limbs. If this transfer station fails, your ability to even stand or walk is immediately compromised.
So that makes total sense. It's where all that force converges and gets redirected.
Exactly. But its secondary function is just as vital: protection and support. By forming this kind of bowl-shaped lesser pelvis, it provides a rigid protective casing for the urinary system, the genital systems, and the very end of the digestive tract. Those viscera are delicate, and they really need that deep, bony shelter.
Okay, so if the girdle transfers the weight, then the sacroiliac joints, the SI joints, must be the most crucial connection points in that whole system. They link the spine, the axial column, to the legs, the lower appendicular skeleton. And they're kind of famous, aren't they, for being highly stressed but low mobility joints?
You're absolutely high stress by design.
Mm-hmm.
And you mentioned low mobility. That's key. These joints prioritize stability way over movement.
Yeah.
The surfaces themselves, the auricular surfaces of the sacrum and the ilium, are actually quite irregular and interlocking. Think of them like complicated puzzle pieces.
Ah, okay.
That helps with static stability. But the real genius, the clever part, is how the ligaments actually use the load itself to reinforce the joint.
Okay, see, that's the bit that always seems a bit counterintuitive. You'd think downward weight would just drive the sacrum down and maybe loosen the joint. So what's the engineering trick here that makes it stronger under load?
Right, this is the biomechanical marvel. It relies on the specific orientation of the strongest ligaments, the interosseous and the posterior sacroiliac ligaments. These ligaments run obliquely, so sort of upward and outward from the sacrum to the ilia. Now, when your body weight pushes the sacrum down, these ligaments naturally become taut.
Makes sense.
But because of their oblique angle, the resulting tension doesn't pull the sacrum away. Instead, it creates this really powerful force that pulls the 2 ilia inward, tightly compressing the sacrum between them. It's like a wedge lock.
Wow. So the very weight we carry acts like its own suspension system, locking those irregular surfaces tighter together.
Precisely. The stronger the downward force, the greater the compressive lock on that joint. But that compression creates another potential problem, which is where this suspension bridge analogy really comes into play.
Okay.
Because the weight is transmitted slightly anterior or forward relative to the joint's rotational axis, the sacrum naturally wants to tip forward rotate anteriorly and inferiorly. We call this force nutation.
Right, like it's trying to nod forward, so we need something to stop that forward tipping.
Exactly. To prevent that nutation, we have two extremely strong accessory ligaments that act like guy wires on a bridge. The sacrotuberous and sacrospinous ligaments. They anchor the lower part of the sacrum and the cossates firmly to the ischium, specifically the ischial tuberosity and spine.
Oh, okay.
They resist that tendency of the sacrum to pitch forward under load, keeping the entire weight transfer system balanced and preventing the whole ring from sort of collapsing or rotating inappropriately.
That's just a phenomenal level of biomechanical insight. So if the downward weight is what stabilizes the SI joint, does that mean that things like chronic SI joint pain or instability could often be related to, say, poor muscle tone or postural issues? Things that prevent that necessary compressive force from being directed properly?
Absolutely. That's a
Yeah.
huge clinical point. If you lose the dynamic muscular support, think your deep core muscles, your gluteals that position the ischium correctly, then the joint has to rely solely on passive ligamentous tension.
Which isn't ideal.
No, it can lead to excessive micromovement, inflammation, and eventually chronic pain. The SI joint is a perfect example of where passive stability, the ligaments, must work hand in hand with dynamic stability, the muscles, to handle the stresses of daily life. Hashtag 1.3, the pubic symphysis and sacrococcygeal joint.
Okay, let's move around to the front. We find the pubic symphysis, which completes that bony ring anteriorly. It looks like a relatively simple cartilaginous joint compared to the SI joint.
It is a classic secondary cartilaginous joint. That means it has hyaline cartilage on the articulating bone surfaces, but also a central, dense, fibrocartilaginous interpubic disc in between.
Right.
While it looks simple structurally, it's very heavily reinforced by surrounding ligaments.
And the reinforcement seems particularly strong underneath, doesn't it?
It is, yeah. The inferior pubic ligament, sometimes called the arcuate pubic ligament, is this massive, thick arch of fibers. It smooths out and rounds the lower border of the symphysis, and it's absolutely crucial for reinforcing the integrity of the whole pubic arch. It's also worth noting here that the fibrocartilaginous disc itself is pretty consistently wider and maybe a bit thinner in women compared to men.
And that structural difference, the width of the disc, that points directly towards the clinical need, doesn't it? Maximizing space for childbirth. That seems to be the main differentiating factor in the overall pelvic architecture between sexes.
Precisely. It's all about facilitating passage. And speaking just briefly of the very tail end, we have the sacrococcygeal joint. This is another secondary cartilaginous joint connected by an intervertebral-like disc and reinforced by anterior and posterior sacrococcygeal ligaments.
Doesn't move much.
It allows for a small amount of movement, primarily flexion and extension, sort of a backward tilting. This can actually be quite critical during defecation or, again, during childbirth to increase the outlet diameter slightly.
Let's dig a bit deeper into those sexual differences then, because they really transition from being just anatomical details to crucial clinical considerations. What really defines the typical female pelvis, the gynecoid pelvis?
Well, the characteristic features of the gynecoid pelvis are all geared towards optimizing that pelvic canal for the passage of a fetus. So this generally means the overall structure is wider, it's shallower from top to bottom, and the pelvic inlet, the top opening, tends to be more oval or even circular rather than the kind of heart shape often seen in males.
And what are the clinical stakes when doctors are assessing the structure, say, before childbirth?
Oh, the stakes are enormous, especially in obstetrics. Clinicians absolutely must determine the key pelvic diameters, particularly the anteroposterior diameter of the pelvic inlet, often called the true conjugate.
Why is that one so important?
Because if a woman presents with an atypical pelvis, maybe one that's too narrow, or features a sacrum that juts forward too much, or just has unusual dimensions, it might severely complicate or sometimes even preclude a vaginal delivery. So accurate measurement is a really key pre-delivery assessment.
And nature actually offers a kind of temporary solution to this tight squeeze just before birth, doesn't it?
Yeah.
And it's tied directly to those ligaments we just discussed.
Yes, absolutely. The hormonal changes in late pregnancy, primarily driven by a hormone called relaxin, cause a controlled relaxation and softening of these usually robust pelvic ligaments. That includes those strong SI ligaments and the pubic symphysis.
So they get looser.
Exactly. This increased flexibility allows the joints to give or separate slightly, which maximizes the dimensions of the pelvic canal, often just enough to allow the fetal head and shoulders to pass through.
So it's like a temporary engineered compromise. You trade stability for flexibility right at that critical moment.
It's the ultimate physiological trade-off.
Yeah.
However, this necessary relaxation is the very reason why many women experience pelvic instability, often referred to as pelvic girdle pain, or PGP, during the later stages of pregnancy and sometimes afterwards. Those suspension bridge ligaments are functionally looser, which can lead to chronic discomfort until they fully tighten back up postpartum.
Okay, so we've built the bony foundation, the girdle. Now we need to sort of clad the interior walls of the lesser pelvis and, maybe most critically, build the floor that actually holds the viscera up. Hashtag 2.1, the muscular walls and ligamentous foramina.
Right, so the pelvic cavity is walled in by a combination of muscle padding and ligaments. Laterally, the walls are substantially padded by the obturator internus muscles. These originate from the inner surface of the obturator membrane, which covers the obturator foramen and the surrounding bone.
And posteriorly, it's a bit different back there, isn't it?
Posteriorly, the architecture is quite dynamic. It involves those ligaments acting less like anchors and more like, well, architectural fillers, bridging gaps in the bone to create passageways.
You mean turning the notches into holes?
Exactly. The big gaps created by the sciatic notches in the hip bone, the greater and lesser sciatic notches, are spanned by those powerful ligaments we mentioned earlier, the sacrotuberous and sacrospinous ligaments.
Ah, the guy wires.
Precisely. By bridging these gaps, they transform the notches into the greater and lesser sciatic foramina. And these foramina are absolutely vital exit and entry points for major nerves, blood vessels, and muscles going to and from the gluteal region and perineum.
And which muscle really dominates that posterior landscape, passing through one of those foramina?
That would be the piriformis muscle. It originates from the anterior surface of the sacrum, runs laterally, and then exits the pelvis via the greater sciatic foramen to attach to the top of the femur. It forms significant padding for the posterolateral wall, and its close relationship to the sciatic nerve as it exits the pelvis is clinically very, very important. Think piriformis syndrome.
Right. Now, for the pelvic floor itself, this muscular sheet that separates the pelvic cavity above from the perineum below, we often talk about it as being like a dynamic hammock or a trampoline.
That's a good analogy. It is arguably the single most important structure for supporting the pelvic viscera against gravity and against the massive sudden pressure fluctuations we generate just by living, coughing, lifting, laughing.
Structurally, what does it look like?
It's generally funnel-shaped, and it's composed of two main muscle groups. Posteriorly, there's the smaller CH.6 muscle. But the much broader, more substantial, and clinically critical component is the levator ani muscle group.
Okay, levator ani, that's not just one muscle though, is it? It's a trio. Let's make sure we break down the components for the listener.
You're right. It's a group. It consists of moving from lateral to medial, the iliococcygeus, which is the most lateral part. The intermediate fibers are the pubococcygeus, and then the innermost, and I'd argue most functionally critical component, is the puborectalis.
Let's put a real spotlight on that puborectalis. It's not just part of a flat sheet. It's described as a specific U-shaped sling. Why is that particular shape, that morphology, so absolutely essential to our ability to stand upright and function?
The puborectalis is really the key to human fecal continence, and it's directly tied to our evolutionary shift to bipedalism. It forms this U-shaped loop of muscle fibers that arises from the back of the pubis on one side, wraps posteriorly around the junction of the rectum and the anal canal, what we call the anorectum, and then returns to attach to the pubis on the other side.
And it's working all the time, like unconsciously.
Yes. Its constant background tonic contraction pulls that anorectum forward, creating a sharp anterior bend. This forms the crucial anorectal angle.
Okay.
If you're standing or sitting, this angle basically acts like a kink in a garden hose. It provides the primary mechanism for passive fecal continence, stopping stool from descending unintentionally. If this muscle relaxes, the angle straightens out and passage becomes possible.
Wow. So basically, we spend our entire lives maintaining this unconscious low-level clench with that puborectalis sling just to maintain control and dignity.
Pretty much.
So what happens when we put sudden massive pressure on the system, like a huge cough or lifting something heavy?
That's where its dynamic role really shines. If you cough violently, sneeze hard, lift a heavy weight, or even just strain, your intra-abdominal pressure skyrockets instantaneously. The levator ani, and particularly the puborectalis, actively contracts reflexively at that exact moment.
Like a reinforcement.
Exactly.
Yeah.
This powerful, momentary contraction pulls the viscera slightly upward, helps reinforce the external sphincters, and further tightens that anorectal angle. It assists the involuntary internal sphincter and prevents the accidental loss of continence under stress. It's a vital dynamic safety net. Hashtag tag 2.3 pelvic fascia and organ support.
Okay, the muscles provide that dynamic support, but they can't be sufficient just on their own, can they?
Mhm.
We need the connective tissue, the fascia, to sort of compartmentalize things and anchor the organs properly. How do we generally categorize the pelvic fascia?
We usually define three related categories, though they
Mhm.
blend together. First, there's the parietal pelvic fascia. This is the layer that lines the internal surface of the muscular walls we just talked about, like the obturator internus and the levator ani. Think of it like wallpaper on the muscle. Second, there's the visceral pelvic fascia. This is the adventitial layer that directly ensheaths the organs themselves, the bladder, rectum, uterus, vagina. It's like the outer skin of the organs within the pelvis.
Right. And then the really interesting stuff structurally seems to be the tissue between those two layers. It isn't always just loose packing material, is it?
Exactly. That tissue between the parietal and visceral layers is generally loose connective tissue, and we call it the endopelvic fascia. But, and this is critical, in specific areas, particularly areas under high mechanical stress, this loose tissue condenses and thickens into exceptionally tough, fibrous sheets and distinct ligaments. These condensations are what truly anchor the pelvic organs in their specific positions and provide passive support.
Okay, so what are some of the key anchor points or ligaments that arise from this condensation process?
Well, there's a really important continuous bilateral band called the tendinous arch of the pelvic fascia. It runs sort of horizontally along the lateral pelvic walls from the pubis back towards the ischial spine area. The organs are essentially suspended from or connected to this arch and other condensations.
Like what?
For example, anteriorly, we see the puboprostatic ligaments in the male, which anchor the prostate to the back of the pubis, or the pubovesical ligaments in the female, connecting the bladder neck area to the pubis. Posteriorly, structures like the sacrogenital ligaments, or uterosacral ligaments, connect the cervix and upper vagina back toward the sacrum, providing posterior support.
And the female reproductive system, with the uterus and vagina sitting centrally, seems like it would need an additional specific lateral suspension system, especially given the weight and mobility of the uterus and the bladder sitting on top of the vagina.
It does. And that crucial lateral support structure, particularly for the vagina, is often referred to as the pericolpium. This consists of the condensations of endopelvic fascia laterally, attaching the sides of the vagina out to that tendinous arch of the pelvic fascia on each side.
So it's like a suspension bridge for the vagina.
In a way, yes, this is fundamental support. Since the bladder base often rests directly on the anterior vaginal wall, the pericolpium is necessary to help the vagina absorb that pressure and bear the weight, ensuring the entire central column of organs stays supported and doesn't collapse downward.
It sounds like brilliant engineering, but it also sounds like it has a major vulnerability, and that vulnerability seems to be childbirth. Given the sheer mechanical forces involved, the failure rate of this fascial and muscular support system seems, well, tragically high.
It is unfortunately common, and vaginal childbirth is the primary cause of chronic pelvic floor dysfunction. The levator ani muscles are highly susceptible to stretching, tearing, or even avulsion being pulled off their bony attachments during vaginal delivery, particularly with prolonged or difficult deliveries, large babies, or forceps use.
Which specific muscles tend to take the brunt of that damage?
It's almost always the medial components, the ones most directly stretched by the descending fetal head. So that's the pubocondyus and, critically, the puborectalis. These muscles form the narrowest part of the funnel through which the baby must pass. And remember, they are the primary stabilizers of the urethra, the vagina, and the anal canal.
So when that support system is compromised, stretched beyond its limits, or actually torn, what are the immediate, often life-altering consequences that women experience?
Well, fundamentally, we see a failure of support, which typically leads to three major categories of problems. First, the loss of that dynamic muscular support, particularly around the urethra, results in urinary stress incontinence.
That's the leaking with coughing or sneezing.
Exactly. It's the involuntary dribbling of urine precisely when intra-abdominal pressure rises suddenly. That dynamic safety net we talked about is gone or damaged.
Okay, that's one. What's the second major consequence?
The second is mechanical descent, or pelvic organ prolapse. When the supporting fascia, like the pericolpium or uterosacral ligaments, and the levator ani hammock itself are weakened or torn, the organs they support can descend. This could be the uterus dropping down, uterine prolapse, the bladder bulging into the vagina, systole, or the rectum bulging into the vagina, rectus. They descend into or sometimes even protrude out of the vaginal opening because their support structure is no longer structurally intact.
And finally, connecting back to the puberactalis sling, which we spent so much time on, tearing that must obviously compromise fecal control.
It's a direct and devastating link. If you disrupt that U-shaped loop, you effectively straighten out the anorectal angle. This compromises the primary passive mechanism of fecal continence. Pairing of the puberactalis, or significant damage to it, almost inevitably guarantees varying degrees of fecal incontinence, really underscoring just how fundamental the integrity of that single muscular sling is to basic daily human function and quality of life.
Okay, we've built the bony frame, the muscular floor, and the fascial anchors. Now, before we dive into the organs themselves, we need to look at the lining, that serous membrane, the peritoneum, which kind of drapes over the pelvic viscera. It's often described like a delicate silk sheet. How does the peritoneum interact with the organs down here, given that most of them sit quite deep in this bony basin?
Right. Unlike, say, the small intestine, which is mostly intraperitoneal, fully wrapped, the pelvic organs are largely subperitoneal or infraperitoneal. This means the peritoneum, which is continuous with the abdominal peritoneum, drapes down from above and only covers the superior or uppermost surfaces of the pelvic organs, like the top of the bladder, the top and back of the uterus, the upper part of the rectum, before it sharply reflects off them and onto the pelvic walls.
And this draping, this reflection, creates important potential spaces, doesn't it? The pelvic pouches.
Exactly. These reflections create crucial potential spaces known as the pelvic pouches. And because of the presence of the uterus in females, these pouches differ structurally between males and females.
Okay, let's start with the male pelvis. How does it look there?
In the male pelvis, the peritoneal arrangement is relatively straightforward. The peritoneum drapes over the top of the bladder and then reflects directly onto the anterior surface of the rectum. This creates a single, relatively simple, lowest point or pouch between the two, the rectovesical pouch.
Okay, one pouch in males. But the female anatomy, with the uterus sitting right in between the bladder and rectum, that must result in two pouches.
Precisely. In females, the peritoneum comes down over the bladder, then reflects onto the anterior surface of the uterus, creating the first, usually shallower pouch, the vesicouterine pouch between bladder and uterus.
All right.
Then the peritoneum continues up and over the uterine body in a fundus at the top, and then drapes down the posterior surface of the uterus and upper vagina before reflecting up onto the anterior surface of the rectum. This creates the second, typically much deeper and far more clinically significant space, the rectouterine pouch.
The rectouterine pouch. That has a famous anatomical name, doesn't it? An eponym.
It does indeed. It's also widely known as the pouch of Douglas. And, it's arguably one of the most clinically relevant potential spaces in the entire body.
Why? What makes that specific little space so vital in clinical practice?
It boils down to gravity. Whether you are standing upright or lying flat on your back, supine, the rectouterine pouch is typically the absolute lowest, most gravity-dependent recess within the entire continuous abdominopelvic peritoneal cavity.
Ah, so stuff collects there.
Exactly. Therefore, if there's any free fluid accumulating within the peritoneal cavity, whether it's blood from a ruptured ectopic pregnancy, pus from appendicitis or pelvic inflammatory disease, or fluid from ascites or generalized peritonitis, it naturally tends to drain downwards and pool right there in the pouch of Douglas.
So it acts like a natural collection basin for anything pathological going on higher up in the abdomen or pelvis.
It functions precisely as a drainage basin, and because of that, it becomes a key diagnostic site. For instance, clinicians can perform a procedure called choledocentesis. That involves passing a needle through the posterior fornix of the vagina, which lies just anterior to the pouch, to access the pouch of Douglas directly. They can then aspirate any fluid present to help make a diagnosis, like confirming internal bleeding, or even drain a collection like an abscess. This direct anatomical relationship really highlights how the peritoneal lining, though it seems like just a passive sheet, dictates the flow and localization of disease processes.
Okay, we've established the structural geography, the walls, the floor, the lining. Let's bring life into the pelvis now. Talk about the complex arterial supply and the dense nervous architecture that runs through it.
Right, the pelvis is incredibly vascular. It has a very rich blood supply, dominated primarily by the internal iliac artery on each side. This is one of the two major terminal branches of the common iliac artery.
And we noted earlier, didn't we, that the branching pattern of this internal iliac artery is notoriously variable. That must make surgery in the lateral pelvic wall quite challenging.
Oh, highly variable. It's one of the most variable arterial trees in the body. Surgeons often have to rely more on identifying key structures and relationships rather than expecting a textbook fixed branching pattern. However, what really compensates for this unpredictability is the immense network of anastomoses, connections between different arterial branches that exist throughout the pelvic region, both within the branches of the internal iliac and with arteries coming from outside the pelvis, like the femoral or inferior mesenteric arteries.
So there are backup routes.
Exactly. This extensive collateral circulation provides vital redundancy. If one major pelvic vessel happens to be ligated during surgery or blocked by disease, blood can often still reach the tissues it supplies via an alternative route, which helps minimize the risk of localized tissue death or ischemia.
Which specific arteries act like major exit ramps, carrying blood out of the pelvis to supply structures like the gluteal region or the perineum?
Those would be the major paired parietal branches, the ones supplying the walls and exiting the cavity. The superior gluteal artery is often the largest branch, typically arising from the posterior division of the internal iliac. It makes a sharp turn backward, usually passing between the lumbosacral trunk and the S1 nerve root to exit the pelvis above the piriformis muscle through the greater sciatic foramen, heading straight for the gluteal muscles.
Okay.
Similarly, the inferior gluteal artery typically exits below the piriformis muscle, also heading to the gluteal region and back of the thigh. And the internal pudendal artery, which is the main artery of the perineum, also exits via the greater sciatic foramen, loops around the sacrospinous ligament, and re-enters the pelvis minor briefly before heading into the perineum proper via the lesser sciatic foramen.
What about the small vessels that supply the integrity of the sacrum itself and the structures within the sacral canal?
For that, we have the lateral sacral arteries. They're usually superior and inferior ones. These are critical because they run down along the sacrum and send spinal branches through the anterior sacral foramina. These branches supply the spinal meninges, the nerve roots within the sacral canal, the bone itself, and also the overlying erector spinae muscles.
And you mentioned one other artery earlier, the median sacral artery. It sounded like an important midline landmark. Tell us a bit more about that one.
Ah, yes, the median sacral. It's a fascinating little structure. It's a small, unpaired vessel, meaning there's only one right in the midline. It typically arises from the very back surface of the abdominal aorta, just near its bifurcation into the common iliac arteries. It then descends straight down in the true midline, lying directly anterior to the lower lumbar vertebrae, the sacrum, and the coccygis. Clinically, as you said, it's a gift to surgeons doing laparoscopic or retroperitoneal procedures because it serves as an instant, reliable midline indicator on the posterior pelvic wall. And embryologically, it's quite interesting too. It actually represents the reduced tail end of the embryonic dorsal aorta. So it's a little peek into our developmental history.
Okay, blood supply sorted. The nerve supply down here seems equally, if not more, dense and complex. It forms this tangled web that has to service everything from the pelvic organs themselves to the entire musculature of the lower extremity.
It is incredibly dense. The ventral rami of the lower lumbar, L4, L5, and the sacral, S1, S4, and coccygeal spinal nerves leave the spinal cord, pass through the intervertebral and sacral foramina, and immediately fan out to form the major nerve plexuses of the pelvis. These are primarily the sacral plexus and the smaller coccygeal plexus. These plexuses quite literally form a dense, complicated mat or bed of nerves that rests upon the posterior and lateral walls of the pelvis, primarily lying on the anterior surface of the piriformis and coccygees muscles. And out of this complex nervous matrix emerges the largest single nerve in the entire human body. Right. Indeed. The massive sciatic nerve, formed from nerve roots L4 all the way down to S3. It's destined for the lower limb, providing the motor supply to the hamstrings, flexors of the knee, and virtually all the muscles below the knee, as well as much of this sensation. We also see the superior gluteal nerve, supplying hip abductors like gluteus medius and minimus, and the inferior gluteal nerve, supplying gluteus maximus, emerge from the sacral plexus here, typically exiting the pelvis via the greater sciatic foramen, along with the sciatic nerve.
But the nerve that really governs the function of the region we focused on today, the pelvic floor muscles, the sphincters, the perineum, that's the pudendal nerve, isn't it?
Absolutely. The pudendal nerve arising from roots S2, S3, and S4 is really the star of the show for this particular deep dive into pelvic structure and function. It is the primary somatic, meaning voluntary motor and sensory nerve, of the perineum. It follows that complex path out of the greater sciatic foramen, around the sacrospinous ligament, and into the perineum via the lesser sciatic foramen.
And what does it supply?
It gives sensation to most of the skin of the perineum and the external genitalia in both sexes. And, crucially, it provides the motor innervation to the muscles of the perineum, including the superficial and deep perineal muscles, and critically, the external voluntary sphincters, both the external urethral sphincter and the external anal sphincter. Its integrity is absolutely fundamental to both normal sexual function and our ability to consciously control urination and defecation. Hashtag tag 4.3 autonomic nerves and clinical vulnerability.
We've covered the somatic nerves. What about the autonomic contribution to pelvic function, the involuntary stuff?
The autonomic system here is quite complex, involving both sympathetic and parasympathetic components organized into pelvic plexuses. But focusing just on the sympathetic side for a moment. The sacral sympathetic trunks are the downward continuation of the lumbar sympathetic trunks. They descend on the anterior surface of the sacrum, just medial to the sacral foramina. They eventually converge anteriorly, usually over the coccyx, at a single midline structure called the ganglion impar.
And their main job.
While they contribute some fibers to the pelvic plexuses supplying the viscera, their primary function is actually to provide postsynaptic sympathetic fibers, mainly for vasomotor control of blood vessels, piloerection, and sweat glands, that travel out with the sacral spinal nerves to supply the entire lower limb.
Okay, let's wrap up by touching on the clinical dangers inherent in this really packed neurovascular space. We mentioned childbirth injury to the muscles. It must also impact the nerves quite often.
Absolutely. The fetal head, especially during a prolonged or difficult descent through the pelvic canal, can directly compress the mother's sacral plexus, that whole mat of nerves lying on the piriformis against the bony pelvic wall. This compression can cause nerve irritation or temporary damage, leading to pain, numbness, or tingling that radiates down the distribution of the sciatic nerve or other branches into the lower limbs. It's a type of transient sciatica related to childbirth, and it can be quite severe sometimes.
And finally, surgical vulnerability. Damaging these nerves during pelvic surgery must be a major concern.
It's a constant consideration for surgeons operating in the pelvis. The obturator nerve, for instance, which isn't part of the sacral plexus but arises from the lumbar plexus higher up, L2, L4, runs along the lateral pelvic wall on its way to the medial thigh. It's particularly vulnerable to iatrogenic injury accidental damage during surgery, especially during procedures like extensive pelvic lymph node removal for cancer.
What happens if it's damaged?
If the obturator nerve is damaged, the consequence is often painful spasms and significant weakness of the adductor muscles of the thigh, making it difficult to bring the leg towards the midline, as well as sensory deficits along the medial aspect of the thigh. Surgeons absolutely must identify and navigate around this dense, crucial bundle of nerves and vessels with extreme care during any pelvic procedure. Hashtag outro.
Wow. So this deep dive has really allowed us to construct the foundational architecture of the pelvis piece by piece. We've moved from the fundamental weight-bearing bony girdle and its clever SI joints
Using load to create stability.
to the dynamic, absolutely critical muscular floor, the levator ani. We've seen how the fascia isn't just packing material, but forms essential supportive ligaments, and how the entire region is powered and controlled by this incredibly variable but thankfully redundant neurovascular network.
And if there's maybe one core insight or structure to really take away from understanding this pelvic foundation, it has to be the fundamental reliance on the puborectalis sling.
Yeah, that U-shaped muscle seems key.
It really is. It represents such a complex evolutionary trade-off, doesn't it? We gained bipedalism, the ability to walk upright, and with that came the absolute necessity for that constant tonic muscular contraction just to maintain basic fecal continence against gravity.
And the inherent vulnerability of that very sling, which, as we discussed, is taxed often to the breaking point during childbirth, is such a stark reminder of the engineering compromises built into the human body.
It really is.
We achieve this amazing upright posture and efficient movement, but in doing so, we introduce a structural weak point that can unfortunately result in devastating lifelong consequences like prolapse or incontinence for so many individuals, particularly women. It truly makes you appreciate the constant, completely unseen work our bodies are performing every second just to maintain equilibrium and function.
It really is the ultimate physiological balancing act of function versus inherent structural form, a constant negotiation.
Well, our journey through the pelvis continues next time. We've now established the walls and the floor. Next, we'll shift our focus entirely to the structures contained within this protective basin. We'll start by detailing the intricate network of urinary organs, then the terminal digestive organs, before we finally move on to the reproductive viscera in the subsequent sessions.
Sounds good. Lots more detail to uncover in there. Until then, keep analyzing those complex sources.
Thanks for joining us for this deep dive into the pelvic framework on bookfulness.